Okay. Hello, 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 everyone. I just want to say hello. This is the final class of our session, of our 4-week session. And thank you so much. Ms. Mills says, my mic sounds nice. Check one. All right, everybody. So just um if you have comments, go ahead, type them in the chat. I want to say hello to my team. Hello, Mr. Sandeep. Hello, hello, hello. Hi, I don't know if Miss Haley is here or not. Yes, she is. Hi, Miss Haley. Hi, Ms. Mills. Hi, team. Let me see if my interns are here. I know Miss Beth is here. I know, but I didn't see her in the chat. Oh, hi, Miss Vina D. Hello, hello, hello. Okay, everyone. If I missed anyone, I'm going to get you. I am. I do want to tell you that this is the final class and we have a lot of stuff to do. And you know what? We're going to be a little longer. Yeah, we're going to be at until 1:30. So if you have to go, definitely watch the playback. And I just want to remind everyone that the goals of the presentation are number one, to learn common CPT modifiers. Number two, learn common HCPCS Level II modifiers, specifically anesthesia. And number three, we want to bring you closer, one step closer to modifiers mastery. You're not going to learn everything, but you're going to learn some good things. Yes, very, very pertinent for this exam. So if you learn something, that's a whole lot, I promise.
Hi, Miss
All right.
J. I'm sorry to
Hi.
interrupt. Can you please check the mic connection?
So it's again not connected, huh?
Yes, Miss J. It seems so.
Oh, wow. Okay, hang on, everyone. Okay, how do I sound? Do I still sound like it's background noise?
I can still hear the background noise, Miss J.
This is interesting. Hold on one moment. Interesting. Okay, how's this?
It sounds
Still the
much better,
same?
Miss J. Sounds much
Oh,
better.
okay. It might have. Oh, okay. Thank you so much. All right. Thank you, everyone. Yeah, you might have been able to hear me, but the background noise you all could hear. So I wanted to get rid of that. Thank you so much, everyone. All right. So again, we want to bring you one step closer to mastery. And today's class is going to end around 1:30. So if you have to go, I understand. And just to let you know, this is the 4th week, and today we're going to talk about modifiers 24, 25, 57, 26, TC modifier, and modifier 62, 66, 80, 82, 81, 82, and AS. Not really AS, I'm just going to mention it. And we're going to talk about anesthesia modifiers. Essentially, these pertain to who performed the service. Now, I have a poll. It's a hand poll. Let me know. How comfortable are you with coding modifiers 22, 52, and 53? A, I'm confident. B, I'm okay. C, so. D, I need help. Or E, what are modifiers? All right, coders, I'm going to need you to just kind of, don't pause on these, because if you don't know, it's okay. It is. Let us know, coders. Let us know. All right. While you're putting those in, I'm going to give you a moment. Hi, Case. Welcome, welcome. That's our intern. Okay. All right. So I'm going to move on. Thank you so much for letting me know. Next question. This one pertains to modifiers 50, 51, and 59. All right. Wow. Good, good, good. And finally, how comfortable are you with modifiers 58, 78, and 79? Okay, so I do want to tell you at any time you can go and watch the playbacks. The playbacks are, you can get to them by just clicking on the link of the live. So where you how you got in here, you can just go watch the playback the same way. Or I also put it on the 16-week the free YouTube course. I put it on there so you can watch the playbacks and anytime watch them. I may go a little fast, and today that might be the case too. So, what I'd like to do, I want to know how well do you know these modifiers? All right, so we're going to just go ahead and test your knowledge. Let's do it. All right, so before you do it, here is a quick reference, and you have all of the modifiers here. I'm going to put this quick reference on each page so you have it, and you also have it in your CPT manuals, front, inside cover. Okay? All right, here we go. Which modifier best supports the increased work? A, 47562 modifier, B 47562 modifier, C 47562 modifier, or D 47562 modifier. A patient undergoes laparoscopic cholecystectomy for acute cholecystitis. During the procedure, the surgeon documents severe inflammation, dense adhesions, and distorted anatomy requiring extensive dissection before the gallbladder could be safely removed. The operative time was significantly longer than usual. Okay, coders, what is the correct answer? What say you? Go ahead, put your answers in the chat. And you know what? People are answering. They are answering. And you're not looking up these codes. Well, you don't have to because the modifiers are different. Anytime the modifiers are different, you don't have to look up the codes. You just have to know what the modifiers are. So here are my modifier focused keywords. Number one, severe inflammation. Number two, dense adhesions. Three, distorted anatomy. And four, extensive dissection. Anytime I see this, I'm looking at this, I'm like, wow, these are some extreme circumstances. Yes, severe is extreme, dense is extreme, distorted and extensive are all extreme. And if I can answer yes to the question, if these are extreme, then you know you can use modifier 22, right? So the answer is A. And if you said A, way to go, way to go, way to go. Great job, everybody. Great job. I love it. I love it. I love it. I see you, Kira, Becky, Mello, Cherry, Ashley, Goodwill, Doherty, Lucky, Sherry. I see you all in the chat. I'm glad you all took the initiative to answer the question. Don't be afraid. We all have been there. Okay. Which modifier is most appropriate for the second procedure? A, 11403 12032 51 modifier. B, 1140350 modifier 12032. C, 1140359 modifier 12032. Or D, 11403 12032 59 modifier. A surgeon excises a benign lesion from the patient's upper arm and also performs an intermediate repair of the wound during the same session. Okay, coders, what say you? So, what should you be asking yourself? Well, we got multiple procedures here, right? Yeah. And I see everybody locked in on the same answer. Anybody think it is something else? I'm not telling you it's something else, but if you think it's something else, go ahead and put your answer there. Okay, coders. All right. I want to ask you, can you eliminate any correct answers by applying any rules? Can you eliminate any? And if you can, which one? Well, go ahead, type in the chat. I just want to know if you can eliminate anything. Okay, and say why. Someone said, hey, B and C can be eliminated, and why? Right, right, right. Off bat, you can eliminate modifier 59 sitting on that 11403 at C. You can eliminate that because that violates a critical rule. Modifiers 51 and 59 may never be appended to a primary procedure. It's always a secondary procedure. And why? Well, that's a multiple procedure modifier. And if it's on the first code, the first can't be the multiple procedure. The first code is the primary procedure. Subsequent procedures make it multiple. I'm going to let that marinate. And that's right, Goodwill. That's right, Becky. Yes, yes, yes. Okay, somebody's saying something else now. I see you. I see you. We're getting to that. All right. So, another rule is it's always going to be multiple procedures, that modifier 51, unless it's bilateral or different, right? Okay. So, is this a bilateral procedure? Well, bilateral means same procedure on both sides of the body. And we basically had a benign lesion excised from the upper arm, and then they repaired that wound, that open wound that it left from the excision. So that's not bilateral. It's not the same procedure on both sides of the body. So anything coding for that bilateral procedure has to go, and B has to go because 50 modifier is bilateral. You got to go. Now, we say it's going to be modifier 51 unless you can say something is different about this procedure. And what is different? Well, I went to Appendix A for this, and it's different if it's a different session, different procedure, or surgery. Okay, it might be different surgery, so let's hold on to that. Is it a different site or organ system? No, it's the same site. They're closing up the wound that was left after the excision. Is it a separate incision, excision? No, the second one is a repair. It's not an incision or excision. Is it a separate lesion? No. Is it a separate injury? No. But look at this last one, and this last one is going to supersede everything. If it's something that's not normally carried out at the same time, then it's different. Well, coders, sewing up the area that you've excised a lesion is normally carried out at the same time. So therefore, it is not different, and it's going to supersede this different surgery or procedure. So it's a multiple procedure. And if you said A, way to go, way to go, way to go. All right. Good job, everyone. Good job. Nominals, excuse me. Which modifier is appropriate? A, 35840, 58 modifier, 78 modifier, 79 modifier, or 22 modifier. A patient undergoes abdominal surgery. 5 days later, the patient develops postoperative bleeding and is taken back to the OR for control of hemorrhage. The return was not planned at the time of the original surgery. Well, that's obvious, right? Okay, so what say you? I know that's right, Vermont Mom. Come on, everybody. Let's go. What's the correct answer? And you all are rocking it. Those people that are kind of just taking the initiative and just answer it, question and go. All right, so we got a few in, so I'm going to keep going. All right, so these are my modifier focused keywords. Number one, patient had surgery 5 days ago, and 5 days later, they're back in the OR because they had postoperative bleeding, and that's unexpected. And they returned to that OR during the post-op or global period, right? And that global period, these modifiers 58, 78, and 79 are applicable. And that modifier 78 speaks most because 78 is used when it's unplanned or emergently. That's right, Vermont Mom. Absolutely. So the answer that has 78 modifier, that is the correct answer. And if you said B, outstanding. That's right. Prakash said, beep, 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 beep. That's right. It is 78. Way to go. All right, let's move on. Which modifier best describes the service? 66984, 51 modifier, 50 modifier, 59 modifier, 52 modifier. A patient has symptomatic cataracts in both eyes. The surgeon performs extracapsular cataract removal with intraocular lens insertion on the right eye, then performs the same procedure on the left eye during the same operative session. Okay, coders, what say you? Go ahead, type your answers in the chat. You all are just saying, going for it, right? Good job, good job, good job. Okay, the family's queen is coming through. I see you, Becky. I see you, Candace. I see you, Pamela Stokes. I see you, Sherry, Kira, Ashley, Goodwill, and Mello. They've answered. What's the answer? All right, so we know this is my modifier focus keywords, and this is what I honed in on. This patient had the same procedure on both eyes in the same operative session. So if that happened, it's modifier 50. And if you said B, way to go, way to go, way to go. All right. Which modifier best describes the service? A, 45378, 22 modifier, 52 modifier, 53 modifier, 59 modifier. A patient presents for diagnostic colonoscopy. The physician advances the scope to the splenic flexion due to poor prep. No biopsy or therapeutic procedure is performed. Okay, coders. Now, this is going to be a teachable moment if you don't know it already. So just be prepared. Okay. If you already know it, good. If you don't, it's okay. Okay, good job, everyone, getting those answers in. Well, the what I honed in on was the provider did not examine the entire colon due to poor prep, right? So we might say that's reduced services. However, there is a nuance for colonoscopies. There is a coding nuance, and I think this might be one of the only nuances, one of the few. There might be another one or two, but you're going to know this one today. All right. So under endoscopy, the guidelines, and here are the endoscopy guidelines. This section here is where you're told which modifier you use for which circumstance. When performing a diagnostic or screening endoscopy procedure, you need to append modifier 53 if the physician is unable to advance the colonoscope or colonoscope to the cecum or colon small intestine anastomosis due to unforeseen circumstances. So our scope only reached the splenic flexure. So we weren't able to advance all the way to the cecum. So we need to use modifier 53, and you use modifier 52 when it is a therapeutic scope or a surgical scope. Okay, so this was not a surgical scope, it was a diagnostic scope. And because it did not advance to the cecum, it's modifier 53. And these guidelines will supersede the general guidelines. So the answer is C. Now, I put it here for a teachable moment. And if you need to go back and review, definitely play it back and also go visit your guidelines and read it for yourself. Good job, good job, good job, everybody. So, did you all, anybody, look, some of you knew that. Some of you knew it. Okay, good job. If you learn it, that's priceless. You're gonna, you know it. Period. Outstanding. Okay. Which modifier is appropriate for the fracture procedure? Modifier B, 78 modifier C, 79 modifier D, 53 modifier. A patient has a right inguinal hernia repair. During the global period, the patient falls and sustains a displaced distal radius fracture. The same surgeon performs open treatment of the fracture in the OR. Okay, coders, what say you? Okay, they're coming through. Don't, you know what? I'm impressed. I'm impressed. Just have the, just take the initiative. Have no fear. You can do it. You can do it. And there's really, you know what? When you're learning, there's nothing wrong. When you're learning, you're not putting wrong answers in. I'm impressed. Okay, Ma. Okay, the family's queen, Sherry, Kira, Cherry, Lamick. I'm probably not saying it right, but Lamicky, Ashley, Candace, Goodwill. All right, so here are my modifier focus keywords. Number one, this happened in the global period. That means they had a procedure, and now they had some other procedure in the global period, the same time, the same period as the original. And this patient fell, and they had it repaired in the global period. But what I need to know is this related? Is it planned? Was it unplanned? Well, it wasn't planned, but you know what? It's not related. 79 modifier, unrelated procedure in the global period. Way to go. Way to go. Great job, everyone. All right. Which coding best supports the services? A, 116031110 modifier. B, 1160351 modifier, 11102. C, 1160350 modifier, 11102. And D, 11603111051 modifier. And coders, you should be eliminating one answer on site. A patient without even reading because it violates a rule. A patient undergoes excision of a malignant lesion on the left shoulder. During the same encounter, the physician performs a separate biopsy of a suspicious lesion on the right thigh. Documentation supports separate lesion and separate anatomical sites. What say you? What say you? And you are putting those answers in. And I want to know, can you eliminate the incorrect answer by applying the rules? So which answer was I referring to? And why? Anybody know what you can eliminate on site? Those are important because these are time savers. So being able to eliminate when you see modifiers 51 and 59 on a primary principal procedure or primary procedure, you should eliminate it right away. Gotta go. And it's modifier 51 unless it's bilateral or different. Well, if you read the documentation, this patient had a malignant lesion on the left shoulder and then a suspicious lesion on the right thigh. Two different body areas, but they're lesions, right? So they are not bilateral because they're not the same laterality, not the same body part. Okay. So we're going to get rid of C. It's not bilateral. So that leaves us with A and D. And we know that it's D unless it's different or bilateral. Well, I'm going to get my little differentometer. And this is how I'm going to measure if it's different. Different session, different procedure. It could be, but I think this separate lesion just bypasses everything. It's very specific, separate lesion, and therefore it is a different procedure. Because it's distinct. All right, so we're going to get rid of D, and the answer. I'm going to eliminate for a moment. That's right, families clean. That's right. Okay, everyone. That's right, Ms. Vina D. They are crushing it. You're crushing it. Okay. All right. We only have like 2 more to go. Which modifier is appropriate for the return procedure? A, 1316058 modifier, B, 78 modifier, C, 79 modifier, D, 53. A patient undergoes initial debridement of an infected open wound. The surgeon documents that the patient will return to the operating room in 3 days for planned repeat debridement and possible closure. 3 days later, the patient returns as planned and delayed wound closure is performed. What say you? You all are putting those answers in the chat. That's what I'm talking about. Have the confidence to answer. That's what I'm talking about. And I'm going to go. So these are my modifier focused keywords. It's documented that the patient will return to the OR for repeat debridement. So if it's documented, then that means it's planned. In fact, it's staged because they did the first stage and the second or related. And when you have that, that is modifier 58. So if you said A, way to go. Way to go. Way to go. How you doing? How are you doing? How do you feel? Go ahead, let us know how you feel in the chat. All right. Which modifier is appropriate? A, 49505 52 modifier, 59 modifier, 22 modifier, 53. A patient is taken to the OR for an elective hernia repair. After anesthesia is administered and the incision is made, the patient develops unstable cardiac rhythm, and the surgeon stops the procedure for patient safety. What say you? Is it A, B, C, or D? Type your answers in the chat. All right, good job getting those answers in. Here are my modifier focused keywords. The anesthesia was administered, an incision was made, unstable cardiac rhythm, and the doctor stops. You know what? All of this speaks to 53. The procedure was discontinued. And I want to remind you that it's not reduced. It's not reduced because the doctor didn't carry out any of the procedure. The doctor did incise, but did nothing more. So it is D. Way to go, way to go, way to go. Now, if he did a portion of the procedure, then you would say reduced. Good job, everyone. All right, so let's just sum things up. When it comes to modifiers 22, 52, and 53, this pertains to the work that the physician did. Modifier 22, the physician had to do more work. 52, the physician did less work. 53, that physician stopped. Okay? Now, modifiers 50, 51, and 59, we know 50 is for bilateral procedures, same procedure on both sides of the body. Modifiers 50 and 51 cannot be appended to an add-on code. So anytime you see that, it's wrong. Modifiers 51 and 59 may never be sequenced first or sequenced on it or appended to a first procedure code. And remember, it's going to be when you have multiple procedures, it's going to be 51 until you can prove it's bilateral or different. And finally, modifiers 58, 78, and 79. Here are the things. Why is this? Oh, I made a mistake. Oh, I didn't put it here. But we're just going to say 58 is for planned procedures. 78, excuse me, is unplanned procedures. And 79 is unrelated. Doing too many things. All right, so I do want to tell you that modifiers do have value and monetary value. They're going to either increase the payment, decrease the payment, or they're informational. They just tell you about, just give you more context or more information about that procedure. And here is the rule of thumb. Function is what impacts the money, whether it's increasing the doctor's money or decreasing the money. That's going to take precedence over the information. So functional modifiers go first. So you are supposed to append as many modifiers that are applicable, but make sure those functional are appended first. All right, now we're going to get to our discussion and we're going to talk about modifiers. Okay, so Ms. Mills says she can hear my background. I just want to know, can you all hear my background? I don't know. This is something new that's happening. Let me just try.
Yes, Miss J. We can hear.
Oh, wonder what? Interesting. Let me try. Testing, testing. What do I sound like?
I think it's the same, Miss J.
Okay, can you hear me?
I think it's now connected. We'll see.
Okay, testing, testing. How do I sound?
Sounds good, Miss J. I have enabled the background noise minimization. I think that will
Hmm.
work.
Okay, and I did put it on mine as well, so hopefully it works too. All right, thank you, team. Thank you, thank you, thank you. I don't know, this is something new. Maybe there's an update with them, and maybe I need a new headset. But nonetheless, when you don't forget that your modifiers are in the front inside cover of your CPT manual and your Appendix A, that's where you can get the complete definition of those modifiers. So they are your friends. Now we're going to talk about evaluation and management modifiers. And some of you may not even know what evaluation and management is because you haven't reached evaluation and management in your studies, but I will do my best. Just know that evaluation and management is not the procedure. Thank you, Mr. Sandeep. It's not a procedure, but it is the doctor visit. Think about it. We go to the doctor, so there are codes for it. So, and they look like this. They're in the 99,000 code series, and it's in the front of your manual. Now, the global period is significant, right? Because you can't, the global period really pertains to visits and anything in the global period. So generally, you cannot bill for a related visit in the global period. It is all bundled into the surgery code, but it is one of these modifiers that's going to enable you to pay for a visit in the global period as long as it's not related to that procedure. And if you're not sure about what I'm talking about, global period, I discussed it in week 2. So make sure you watch week 2 of this series. Now, modifiers 24, 25, and 57, they may only be appended to E&M codes. So if you have a scenario where you have surgery and E&M codes, and they stick one of these modifiers on a surgery code, then you know it's wrong. Someone said, hey, is this going to be on YouTube? Absolutely. It's going to be on YouTube. And I'll show you at the end. All right. So here, let's begin our discussion on modifiers 24, 25, and 57. But specifically for modifier 24, patient seen for another condition in the global period, you will append modifier 24. And again, you will append it to the E&M code. Now we've got a procedure. The patient returns to the physician's office for a follow-up visit for gallbladder surgery. During the visit, the patient complained of lower back pain that was not related to the surgery. The physician performed a separate evaluation of the back with moderate medical decision making. The doctor ordered an MRI and diagnosed the patient with sciatica. Okay, coders, can any of you tell me how you would build this encounter? I'll give you a moment. How would you build the encounter? Remember, this patient's there for the follow up of the gallbladder surgery. Would you bill for the gallbladder surgery visit or no? Well, I'll tell you. The only thing you would bill for would be that evaluation and management encounter 99214, and you'll put that 24 modifier on it. And there will be no code for the post-op visit because the post-op visit is bundled into the surgical visit. Good job, Starry, Sunny. Good job indeed. So I want you all to talk in the chat. Let me hear your chatter. Let me know if you understand that. So modifier 24 is used for the global or post-op period because insurance companies and payers are very strict. Generally, nothing gets paid in the post-op or global period unless you have a modifier or some add-on code or something. The rule is no. So we got to make sure our doctors get paid when they're entitled. And if this doctor works up this condition, and she did because she carried out an exam with moderate medical decision making, and she even ordered MRI and a new diagnosis. You all with me? Because now we're going to move on to modifier 25. And yes, I am moving a little fast. I am, but I want to get it all in. Indeed, Candace, indeed. And the key thing is the patient has to be worked up. That doctor's got to do the work. Now, if the doctor he said, my back hurts, and the doctor said, oh, it's probably sciatica, take 2 aspirin and call me in the morning, that's not a full workup. Okay, so the doctor has to earn that visit. All right, now we're going to talk about modifier 25. Modifier 25 is almost like modifier 59, but for E&M codes. So this has nothing to do with the global period, even though you can assign it in the global period if it's applicable, but it has nothing to do with the global period. The patient receives an E&M visit and another service on the same day. When that happens and that visit is distinctly different, then you're going to append modifier 25. The E&M visit is usually bundled into a procedure, usually. So whenever a person comes to the encounter for a surgical visit and the doctor happens to evaluate them for that for that condition, it's bundled generally. But if it's distinctly different, if that exam is distinctly different and necessary, then you can apply modifier 25. Modifier 25 is also used when a physician works up multiple E&M conditions. If the patient goes for one condition and something else is found and that doctor works it up, that's distinctly different. So that's modifier 25. All right, so here's my scenario. We have a 35-year-old patient who came to the physician's office for an annual wellness exam. During the visit, the patient also complained of knee pain. The physician performs a separate evaluation of the knee with low medical decision-making, ordered a knee x-ray, and diagnosed the patient with a torn ACL. All right, coders, if you know what the answer is, go for it. And some of you won't because you haven't studied E&M, and some of you have. So you might be able to say what the answer is. But I will tell you the difference between 24 and 25. 24 is used in the global or post-operative period. 25 is just used whenever. Good job, Becky. Good. She took the initiative and she put the answer in. And I didn't expect anyone to answer. So I'm glad someone did. And the answer is you're going to bill for that wellness exam, $993.95. And you're also going to bill for the evaluation encounter because the doctor worked the patient up and rendered a low medical decision-making MDM, and you're going to put that 25 modifier on that E&M visit. Oh, let's go back. I'll let that marinate. Are you all with me? And if you're not, say, hey, I'm not. I need to know. Now I'm going to continue, and I'm still going to talk about modifier 25. Here's another scenario. A 52-year-old established patient came to the physician's office complaining of right knee pain. The physician performed a separate evaluation of the knee with moderate medical decision making and diagnosed the patient with osteoarthritis of the right knee. After discussing treatment options, the physician administered a corticosteroid injection into the right knee. Yes, Kira, definitely. The more you watch, the more you get it. Definitely. And let me know after you watch. Just respond underneath the video. And from time to time, like once a week, I take an opportunity and read the comments when I can. So let me know if it helps when you watch the playback. All right. So, what is going on here? Well, this patient got a knee injection. Well, the patient came to the doctor's office because she was complaining of right knee pain. That doctor performed um, this worked her up, did a full exam, rendered moderate MDM, and then gave the knee injection. And this is how you would code it: 99214 25 modifier and 20610 for the injection, right? And you might say, well, how did you know to sequence the 99214 first? Well, I knew because I do have an encoder, and I was able to verify which of the two has more value, which one is more valuable. Now, you all don't have that, so you won't be tested on that. Your items will be sequenced. It's not going to put 206 first and 99214 second. That's not going to be an option because you have no way of determining which one has higher RVU value. So this is, in the real world, it would be sequenced this way. So here is my gem that I want to give you. So basically, when you have an E&M encounter or you have surgery and E&M at the same time, you need to ask yourself, what was the reason for the encounter? Now you code the E&M visit if the reason for the encounter was not the procedure. Now, if the reason for the encounter was the procedure, if the reason for the encounter is I'm coming through the door because I know I'm going to have this knee injection, we had planned for this knee injection, then you do not get to code that it related evaluation and management. If you came through the door, you don't know what it is, you just have the pain, the doctor didn't know what it is, and the doctor has to work up that condition and render some type of decision making, then you get to code both. You code the doctor's work. If the doctor did the work, you code it. If he does not, you do not. I'm going to let that marinate. Does that make sense? Talk to me. Let me know. Always ask yourself, what was the reason for the encounter? And then see if the doctor worked it up. Did the doctor examine and render medical decision making? Outstanding. One person said it makes sense. And you know what? All I need is one. Somebody's going to get it. Good job. Thank you. Thank you, Becky and Goodwill. All right. Now we're going to move on to modifier 57. Modifier 57 is relevant when the decision for surgery was made during that encounter, right? And it's pertinent when the decision for surgery was, well, when the actual surgery occurs on that day, or the day after, right? So the decision for surgery was that day, and surgery is that day or next day. So maybe I could say that better. So essentially, when a physician makes the call to have surgery on the day of surgery or the day after, it's codable. He can be compensated for it, but typically it's bundled, right? But if it's on the day of surgery or the day before surgery, then you can use modifier 57. It tells the payer to override and pay this doctor. All right. So we have so just so you know, this modifier 57 speaks to this general coding guideline, CPT general coding guideline right here. This first one, it says this is a part of the surgical package. Yes, this visit, the day of and the day, excuse me, the day before and the day of surgery is bundled into the surgical code. So that visit is bundled right there. But if the decision for surgery is the day before and the day after, you can use this 57 modifier. So this CPT surgical package definition bundles those visits, but this modifier 57, it overrides it. I don't know why they have it like that. Why would you have some override? But anyway, that's what it's used for. All right, so we have a 68-year-old patient who came to the physician's office complaining of right hip pain that had been getting worse over the past year. The physician performed an E&M with moderate medical decision-making and diagnosed the patient with advanced osteoarthritis of the right hip. The physician determined that the patient needed a total hip replacement surgery and scheduled the surgery for the following day. Code the encounter. Now, somebody might say, well, why would you have this surgical package when you can override it? I will say this. Modifier 57 is generally used for complex procedures. So that's why. So small procedures, maybe not, but in the real world, it's generally used for those complex or major surgeries. All right, anybody got the answer? What is the E&M code? Well, if it's moderate medical decision making, 9921457 modifier, we can just guess. All right, and that is the answer. Someone said, oh yeah, playback. I know that's right. All right, so just so you know, we're going to finish up our discussion of E&M modifiers 24. This is unrelated E&M visit in or during that global period. Modifier 25, this is a separate E&M service on the same day as a procedure or same day as another service, E&M service. And modifier 57, this is the decision for major surgery. And there you go. And they call it the global period because it's the day of surgery. All right, everybody. And yeah, it is going to be a little more complex because I gave the others more time, and it's okay. At least your foundation is good. You have a good foundation. When you have a good foundation, it gives you the confidence to just kind of pursue some other things. So as long as you know those previous ones that I've told you, you're good. You are. And remember, these modifiers are in your book. All right, so let's talk about professional and technical components. And these are modifiers 26 and TC. These modifiers are appended to radiology and pathology as well, but typically it's the radiology that people kind of struggle with. So just want to tell you that we do have a really good lecture on TC and 26. So I'm not going to do the trick here. I'm going to try, but no, I'm not going to do as well as this video. So definitely check it out. It is on your playlist. All right, so modifiers 26 and TC modifiers, what you need to understand. Many CPT procedures represent both the professional and technical components of a service. And I'm talking about CPT pathology and radiology procedure codes, right? And this is called a global service code, right? It's global because it has both the professional and the technical part. So it's a global service. That code with no modifier is called a global service. Now, modifier 26 is used when the professional component, when you want to just pull out the professional part of that global code. So if someone only carries out the professional service, they're not entitled to use the full global, but they do need to append modifier 26 to let the payer know that, hey, I've only provided the professional component of this global code. Now, the TC, identifies the technical component only. And I'm going to explain that momentarily, but it's for the technical, and I think the visual will help you a lot. All right. So essentially, if the provider owns both of the professional, like they employ the professional who interprets the film, and they also own the equipment and everything else, then they get to use the global code. 26 modifier is for the person who interprets, provides the professional service of that service or that code. And TC, these are the people who own the equipment. I like to call TC also technical contractor. They own the equipment. Hospitals often own their own equipment, and sometimes they don't. All right, so let's talk about this global radiology code. A global radiological code combines the professional and technical components and other elements, right? Hospitals automatically assign the global code, even if they don't employ the professional, even if they don't own the equipment, they still assign the global code because they own enough of other stuff. They employ the technician, they provide the service, they have other elements and things that they're providing, and just their facility alone is enough that would warrant them to assign a global code. So anytime a hospital is carrying out a radiology, service, and your task is to assign the code, the hospital will always get the global code, no modifier. And that's what a global code is. It's a code without a modifier. Now, providers, groups, and physicians who own their own equipment, they can use the global code too. You have to, at minimum, provide the interpretation, the professional service, as well as the equipment to assign the global code. Again, global code is no modifier. And here is my example. All right, how should the X-ray service be reported? A patient with a right wrist injury was seen in an orthopedic physician's office. The physician performed and interpreted three view X-rays using X-ray equipment owned by the practice. So the physician's office and practice are the same, all right? So the answers that you have to select from: A, 7311026 modifier, B, 73110TC modifier, C, 73110, or D, 7311026 and TC. What say you? Go ahead, put your answers in the chat. There's no wrong answers. Good job, everyone. Good job, good job, good job. All right, so this is the doctor. The doctor works in the physician's office. The office, and the doctor could own the practice too, but the practice owns the equipment and the physician's office. So, how should this be reported? Well, if the entity owns both, then the answer is 73110. So if it's owned by the practice, does the practice employ the doctor, or does the doctor own the practice? 9 times out of 10, he does. So if the doctor is employed by the practice and that practice also owns the equipment, you get no modifier. You get to bill the full code. And also, too, D is structurally wrong. You should never do this. You can just go ahead and assign the global code. When it's both 26 and TC, use the global. All right? So here's my gem. Hospitals and providers who own the equipment use the global radiology code. How you doing, coders? How you feeling? You awfully quiet. You all want me to keep going, huh? Or you all just saying, hey, hurry up and we'll watch the playback. All right. I'm going to go. I'm going to continue. All right. So when that doctor owns the practice and equipment, if the doctor and equipment all come together, go together, you just use that global code, no modifiers. Good. Someone said they're digesting. Someone said, good explanation. All right, let's turn our attention to modifier 26. And this is used by the professional, like the radiologist, the doctor, for their professional services. They pretty much interpret the film, right? Yeah. So how would Dr. Smith report his radiology service? A patient was taken to the hospital ED after falling from a ladder. X-rays of the femur were obtained by the hospital, and Dr. Smith, a physician with radiology group, interpreted the images and confirmed a displaced fracture of the femoral shaft. How do we report for Dr. Smith? A, 73552, B, 7355226 modifier, C, 73552TC. Oh, we have two. Oh, okay. And D, 7355226 and TC. What say you? And for those of you who didn't know, most radiologists are not employed by hospitals. Some are, but many work for independent radiology groups. So if you ever go to the hospital, you'll get multiple bills. You'll get one from the hospital, one from a radiology group, one from a surgeon. That's why. So the radiology group needs to bill for their Dr. Smith, and they would bill it like this: 7355226 modifier. Does that make sense? They did nail it. You did. You nailed it. Don't be intimidated. I know that the reason modifiers some people are kind of worried about it. They're very guideline driven, very heavily guideline driven. Yeah. But when you master these guidelines, you'll find that you'll be able to answer questions very rapidly when you're taking your exam. Those are going to be your friend, those modifiers. All right. So the gem is the professional who interprets those films only. They use modifier 26. That global code is heavy, very, very heavy. Whoever builds that global code, they get a lot of money. So that doctor, even though he's definitely got skill, he's not entitled to just get the full global code. He only gets a portion. And that 26 modifier makes sure he gets the portion that he's entitled to. All right. Finally, we're going to talk about TC, technical component. This TC modifier is used by the technical contractor. Essentially, they're renting out their equipment. Yes. Sometimes hospitals don't have the equipment, right? Have you ever gone and had a radiologic service, a mammogram or x-ray or an MRI, and you stepped into a, some kind of trailer? Well, that's what that is. Portable scans is a technical component, a technical contractor. This entity is able to bill for their services by using the TC modifier. Now, how should Portable Scans LLC report the mammography service? A 54-year-old woman arrived at Mammography Associates for a routine bilateral screening mammogram. She was directed to a mobile imaging trailer attached to the building that was owned and operated by Portable Scans LLC, where the mammogram was performed. I think this picture is really not cool, but it's okay. So Portable Scans LLC billed only for performing the mammogram, while a radiologist from Mammography Associates interpreted the images separately. Okay, so how will we report for Portable Scans LLC? Good job getting those answers in. Come on, you got this. You got it. And I know we're over our hour. Okay. The answer is C, TC, because we are coding only for portable scans, and they are the technical component, technical contractor. Okay. And essentially, this patient went into Mammography Associates. They didn't have the equipment. They subcontracted out to Portable Scans, and Portable Scans said, okay, we'll do it. And we bill for the services. And there you go. All right, so just remember, it's no modifier if the biller owns both. They use that global code. 26 modifier is for the physician who did the interpretation or the professional services. TC, technical contractor, these are the people who actually own the equipment. And there you go. Okay, coders, what say you? Now we've got 2 more to learn. No, we got 3 more to learn. All right, let's do it. Let's do it. And that's right, Miss Haley. They are doing an amazing job. All right, so we've got physicians and qualified healthcare professionals and modifiers 62 and 66. This is a little more straightforward. Now, this is when more than one doctor is carrying out a procedure. So some surgical procedures require more than one surgeon. but it's when the surgeons are working in concert together on one procedure. In other words, you got two surgeons working as co-surgeons, and they're going to use the same procedure code. That's critical. If they are co-surgeons performing the same procedure, but distinct parts of that same procedure, they use the same procedure code and they'll append modifier 62. Now that's for co-surgeons, modifier 62. Now, modifier 66 is used for a surgical team. That's when you have a highly complex procedure and it requires coordinated services of multiple physicians performing different parts of the same procedure. So it's not the same, excuse me, let me rephrase that. Their services are all related to the same procedure, and it could be different parts of a procedure, but different skill set, different. They're not using the same procedure code. I'm gonna let that marinate. They're not using the same procedure code. One surgeon might do a harvest. The other surgeon might take that harvest or graft and use it in a procedure. Another might, more than suture, might anastomose the harvest. It could just be various or distinct skill sets at one time. All right, so let's talk about modifier 62. When both surgeons, two operate as co-surgeons, must be carrying out the same procedure. A 57-year-old patient was diagnosed with a large supratentorial brain tumor and underwent a craniectomy for the excision of the tumor. Due to the complexity of the procedure, Dr. Johnson removed the tumor from the right side of the operative field, while Dr. Rogers simultaneously removed the tumor from the left side. Both procedures were carried out simultaneously. How should each surgeon report the procedure? Is it A, 61510, B, 62 modifier, C, 66 modifier, D, 80 modifier? Yeah, brain surgery. Yeah, place your answers. I think right now they're just like, hey, it's so much. Yeah, it is a lot. And I do apologize, but we're ending today. And I want to make sure I started slow because I want to make sure you know the others. These familiar. You'll get to know these as you use them more. All right. Good job, good job, good job. And the chat said 61510B 62 modifier. Outstanding. They must be co-surgeons and they must use the same procedure code. They're working on the same thing, same exact body part, same procedure. Now, let's turn our attention to modifier 66. This is different. These are multiple specialists, and often they have different procedure codes, right? So I'll just read it out. I'm not reading these as we typically do. I'm reading them out because the answers are similar. They're the same. We have a 46-year-old patient underwent a corporectomy. Hemicorporectomy. It's hard to say. For an extensive pelvic malignancy. Because of the complexity of the surgery, a surgical team consisting of an orthopedic surgeon, a vascular surgeon, general surgeon, plastic surgeon, and urologist worked together throughout the operation. You are coding the services performed by the orthopedic surgeon. How would you code it? Would it be A, 26990, B, 62 modifier, C, 66 modifier, or D, 80 modifier? What say you? And those answers are coming in. And you all have said 66 modifier. Absolutely. Now, this is not realistic. You're not going to have them all working at the same time, but you can. Not this many, but you can. Like the plastic surgeon might jump in when they're finished, or so, but just for the sake of a visual, you got it. So each provider must be performing different parts of the procedure. And this is your team, your surgical team. All right, so just to end things with modifier 62 and 66, 62 is you have 2 co-surgeons, 66, it's multiple specialists, and they comprise a surgical team. Now we're going to move on, and we're going to talk about modifiers 80, 81, 82, and AS. AS, not so much, but this is kind of straightforward. When we're talking about modifiers 80, 81, and 82, 80, these are for assistant surgeons. So they are assisting the physician. Modifier 80 is when the assistant remains throughout the procedure for the entire time. Modifier 81 is when the assistant is there for a portion of the time. And modifier 82, this is only for teaching institutes when a qualified resident was not available. That's when you use that. So if a regular physician or regular surgeon carried out the assistant surgeon, modifier 82, because there was no resident. And it's only exclusive for teaching facilities. All right, so modifier 80 is used when the assistant is full-time. How should Dr. Jones report the procedure? A 72-year-old patient underwent an open right hemicolectomy for adenocarcinoma of the ascending colon. Due to the complexity of the procedure, Dr. Jones assisted the primary surgeon throughout the entire operation, helping with exposure, tissue retraction, hemostasis, and wound closure. Now, we don't know if this is a teaching facility. We don't know if this is a resident or not. The assumption is that it is a resident, but when the documentation specifies that this is a teaching facility, then you know what to do. But we know this is a resident, and what we're focusing on is this doctor remained the full time, right? So the answer are A, 44160, B, 44160, 80 modifier, 81 modifier, and 82. What say you? Well, this assistant is full-time, and the answer is going to be B, 44160, 80 modifier. And some of you might say, hey, these are too easy. The answers are there. They kind of are, but I want you to kind of just go ahead, humor me, put the answers in the chat. Yeah, let me know that you know. All right, so the gem is that the assistant is full-time. When they're full-time, it's 80. Now we're going to move on to modifier 81. That's used when the assistant is part-time. A 64-year-old patient underwent a open total thyroidectomy for a multinodular goiter. The primary surgeon performed most of the procedure independently. Dr. Smith assisted only during the delicate dissection around the recurrent laryngeal nerves and was no longer needed after the portion of the surgery was completed. How should Dr. Smith report the procedure? What say you? Is it A, 60240, B, 60240, C, 6024081, or 82? What say you? All right, so we know this is part-time, right? And we see in the documentation that Dr. Smith only assisted during the delicate dissection, right? So Dr. Smith was part-time, and we're going to append modifier 81. And if you said C, way to go, way to go, way to go. And finally, modifier 82. This is used for teaching institutions only. What is a teaching institute? This is an institute that trains residents. Yes. So if it's a teaching institute and there's no resident available, you're going to append modifier 82. A 61-year-old patient underwent an open partial nephrectomy for a malignant tumor of the left kidney at a teaching hospital. A qualified resident surgeon was unavailable to assist, so Dr. Carter assisted the primary surgeon throughout the entire procedure. How should Dr. Carter report the procedure? Is it A, 50240, B, 5024080 modifier, C, 5024081 modifier, and D, 5024082 modifier? And I'll tell you, you can append 80 and 82 if it was an option, right? On purpose, I did not include that because I really wanted you to see that the answer is 82. If that documentation says that, it's 82. Now, if you have a situation where those keywords are saying, hey, he participated throughout the entire procedure and it was a teaching facility, those are your keywords and you will hone in on them. All right. So the key thing to remember, a teaching institution when no resident was available, it's modifier 82. Good job, good job, good job. So make sure that you know the differences. Modifier 80, full-time. 81, minimum assistant. 82, there was no qualified resident at a teaching facility or institution. And finally, HCPCS Level II, AS or assistant surgeon. Sometimes in the real world, your payer may say, don't use any of these, 80, 81, 82, don't use any of them because we want you to use AS, assistant surgeon. Anytime the payer says that, then that's what you do. You always follow the payer. Now, AS is a HCPCS Level II modifier, and that is a fantastic segue. And we only have 6 minutes, but you know what, coders? I'm going to keep going. I think I'm going to need probably about 10 minutes more, 10 additional minutes. So if you have to go, definitely go. Don't forget to fill out the survey and don't forget to like this up. And I will be back next week with HCPCS Level II. Yes, 4 weeks of HCPCS Level II. All right, so anesthesia modifiers. They are found in the HCPCS Level II manual. You know it's HCPCS when you have at least one letter. One of the characters is a letter, it's HCPCS. The numbers are CPT. You can find them in the CPT manual. And these are appended to anesthesia CPT codes. So yeah, they're interchangeable. You can use these anesthesia modifiers for anesthesia CPT codes. And these identify who provided the anesthesia and how it was administered. And anesthesia modifiers are used by anesthesiologists and CRNAs and their staff. All right. So these are the general anesthesia modifiers. And I'm going to encourage you to watch the AMCI 16-week course. And I believe it's week 6, where we talk about anesthesia and radiology, and you'll learn the different modifiers. What AA is, that's anesthesia personally performed by the, when the anesthesiologist personally performs the anesthesia service. AD, this modifier means a physician medically supervised more than 4 concurrent anesthesia services. QK, an anesthesiologist medically directed 2 to 4 concurrent anesthesia services. QY, an anesthesiologist medically directed 1 CRNA during the anesthesia service. QX, a CRNA performed the anesthesia service under the medical direction of an anesthesiologist. QZ, a CRNA performed the anesthesia without the medical direction of an anesthesiologist. QS, the anesthesia service was provided as monitored anesthesia care, or MAC. And then we have 2 more that we really didn't discuss. Team, we didn't ever discuss these 2, so let's do it. G8, this was MAC for a deep, complex, or markedly invasive surgical procedure. And G9, MAC was performed because the patient had a history of severe cardiopulmonary disease. So yeah, these 2 exist as well. Probably not going to be used as much, but they exist. And here, this is my visual. I gave each one 1. And also here's the replica that we have of, our documentation in we tell our students to document in their CPT manuals in the anesthesia section. Write all this down, write your anesthesia modifiers down. And here are your physical status modifiers. And these anesthesia related modifiers are, these are CPT modifiers. But our focus today is going to be these HCPCS Level II, because it's important that you know how to apply them. So we're going to get right into it. Of the following answers, which best describes the encounter? And you should be able to, if you've already done it, you should go to your page in your CPT where you've documented these key modifiers, and you should be able to pick the correct answer. A 54-year-old patient undergoes, or look in your CPT manual, or excuse me, your HCPCS Level II manual. A 54-year-old patient undergoes a laparoscopic cholecystectomy. Dr. Reyes, the anesthesiologist, personally administers the entire anesthesia service from induction to through emergence. No CRNA or resident participates in the case. Wow, doctor was working. All right, so for the sake of time, I'm just going to let you see what I focused in on. And Dr. Reyes, the anesthesiologist himself, did this service. That's what I honed in on. So which of these modifiers say that? So AA is anesthesia services performed personally by the anesthesiologist. I think I like that. AD is medical supervision by more than 4 concurrent. No. Medical direction of 3 to 4. No. No CRNA. No CRNA. No CRNA. No MAC. No MAC. No MAC. This is A. Anesthesia services performed personally by the anesthesiologist. And good job. Good job. User VG3T3GZ4C. That modifier AA is anesthesia performed personally by the anesthesiologist. Are you guys with me? That's right, Mr. Sandeep. Come on, team. Encourage the people that stayed. Yes. Okay, good job. So you all kind of get where we're going. All right, so look at these modifiers and go ahead and turn to the pages. And we already know what AA is. So you might know what AD is. All right, of the following for 2, QY ADAA. During a busy surgical morning, Dr. Patel is involved in 7 concurrent anesthesia procedures across multiple operating rooms. Documentation confirms she provided medical supervision rather than meeting the requirements for medical direction. Okay, how do we code for Dr. Patel and these 7, supervising these 7 concurrent anesthesia procedures? All right, we're not answering in that chat. I'm gonna move on. And also, if you're watching the playback, I got you. And don't forget to pause too. Pause and answer these questions. All right, so the answer is AD, medical supervision by a physician with more than 4 concurrent anesthesia procedures. Yes. So it's AD. And remember, AD, a physician medically supervises 4 or more concurrent procedures. Good job. Someone said, aha. Okay, a CRNA furnishes the anesthesia for an inguinal hernia repair while an anesthesiologist provides medical direction meeting all required elements. The claim is submitted for the CRNA's portion of the service. Of the following, which best describes the encounter? A, 00830QZ, QY, QX, and AA. All right, coders, what say you? So we've got CRNA was medically directed by an anesthesiologist. This is not correct. I knew I was going to get something incorrect. Anybody want to know what it is? I think it's QY. Anybody want to team? Okay, QY is an anesthesiologist medically directed 1 CRNA during the anesthesia service. QX, a CRNA performed the anesthesia service under the medical direction of an anesthesiologist. That's saying the same thing? Maybe let me go ahead and look at this. All right, so here's the difference. A QY anesthesiologist directing 1 CRNA. A QX, a CRNA directed by a physician. Hey, coders. During the CRNA, but it is very, very specific that QY is directing, the anesthesiologist is directing the service. So the answer is QY. So I do apologize for the error. And I want you all to pay attention to the use of physician and anesthesiologist. Anesthesiologist is a physician, correct? So anesthesiologists can use a physician code, but when there is a specific code for an anesthesiologist, you are expected to use it. So I don't know how that happened. I'm making my adjustments here. Are you all with me? All right, so that was the last one. Outstanding. And we're going to ignore this QX. All right. All right, so I had all these little tests for you all. And what I'm going to do is I'm going to scroll down them. So if you're watching the playback, you can take this test yourself, right? So make sure that when I provide the scenario, press pause, then answer. I'm not going to say anything. I'm just going to run through these, okay? So when you see the scenario, pause, then answer the question. Okay, these are the summaries of all of the modifiers that we've discussed. And I really believe that you studied modifiers 22, 52, and 53. I think a lot of you have a great command of that in 79. Having a command of these will give you an incredible advantage. And being familiar with the rest, you're still going to be in good hands. Okay. All right. So we've discussed evaluation and management modifiers, split in surgical care, return to the OR, altered services, multiple and unbundling of procedures, repeat procedures, surgical teams, labs and tests, and modalities and special cases. So essentially, modifiers modify the procedure in some way. They give you more context and they describe the procedure more comprehensively for the payer. And often that can impact the payment. And coders team, for those of you that want our master keyword or modifier cheat sheet, please put it in the chat. the link in the chat. And for those MCDC students, go ahead and apply your new modifier understanding. You have your AI coaches powered by AMCI and Lucene in your MCDC course. You've got brand new scenarios, and go ahead, take advantage of it. It's like having AMCI sitting right next to you. An AMCI instructor. You got your personal AMCI instructor, and you actually are communicating with the AMCI team when you have questions. So definitely take advantage of it. All right, so just want you to know, congratulations, we have completed our discussion of modifiers, and next week, we're going to talk about HCPCS Level II. And you know where I got that? From you. A lot of you said that on the survey. You said, hey, I want to do HCPCS Level II. Well, it's coming starting next Thursday. 1 hour only. We'll do our best. All right. And in August, we're going to begin a full introduction to medical coding course. It's 8 weeks. So if you're new here, definitely make sure that you come to the introduction to medical coding. If you are an existing student and you go somewhere else, come to the introduction to medical coding. It will strengthen your foundation. It will, I promise you. All right, and finally, someone in this chat said, hey, I want a PCS course. Either I'm going to do a PCS or a CCS, a full course, 8 weeks, 9 weeks in November. So come, stay tuned, stay tuned, stay tuned. The playbacks for modifiers, anyone can see, but the playbacks for HCPCS Level II, you must be a member. You have to be a YouTube member. At minimum, you have to be I think a bronze member. Also, see the CCS. If it's CCS, you're gonna have to be gold to get those playbacks. That's gold. Just come then. It's free. It's free. All right, so we finished all of these sections. And for those of you that are asking for the playbacks, I don't blame you. Just go to our YouTube channel, AMCI Coding, click on play. Click on live, excuse me. Click on live. And then you'll see this session, right? So you'll see all of the sessions, 1, 2, 3, 4. You just click on that and you'll see every single playback. But it's also on the playlist for the 16-week course. Click on playlist, 16-week course, and every single lecture is there. And it looks like this. So don't forget the survey. I know it was a lot, I know, but my goal was to have you learn those 9 and then make you familiar with the rest. And I think you got this. You got it. So please complete the surveys. We do read them. I thank you, thank you, thank you. Oh, and somebody did say on the survey, hey, can you tell us what's happening the next week and this and that? And I do think that we do that, so if we can do a better job, just let me know like why you couldn't see it. Like it's a 4-week series and they're all laid out. So if you couldn't see it, let me know and I can help you through your process, or we can change the way we're doing some things. So I just want to thank you all. I want to thank the team. Thank you, Mr. Sandeep, Miss Haley. Thank you, Ms. Mills. Thank you, Miss Vina D, Miss Beth. I see you, Case. And thank you, coders. I try to say all your names, but you have to excuse me today. I've kept you for too long, but we will see you next week with HCPCS Level II. $4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI, AMCI, AMCI.